Hello, everyone. Thank you for joining today's 2021 Investment Activities and Promoting Interoperability Performance Categories webinar. During today's webinar, CMS will provide an overview of the improvement activities and promoting interoperability performance category requirements for the 2021 performance period of the Merit-Based Incentive Payment System, or MIPS. After the presentation, CMS will take questions as time permits. Now I'll turn the call over to Vidya Selapan, a health insurance specialist at CMS, to begin. Please go ahead.
Thank you, and thank you everyone for joining today's webinar on the improvement activities and promoting interoperability performance categories of MIPS for the 2021 performance year. We're excited to have various CMS subject matter experts on the call to give you an overview of how to participate within these performance categories. Next slide, please. This slide shows our normal disclaimer, which is a reminder that today's presentation is a tool to assist participation in the Quality Payment Program and not a legal document. For official Medicare program provisions, we encourage you to visit the relevant laws, regulations, and rulings for the latest policy changes. Next slide, please. Today's presentation will begin with a brief overview of the Quality Payment Program and the Merit-Based Incentive Payment System, or MIPS. I'll then turn it over to Jacqueline Rappaport to discuss the improvement activities performance category before Elizabeth Holland provides information on the promoting interoperability performance category. There will be time for a questions and answer session following our presentation. You can submit your questions through the chat box at any time. Please note that we hosted an overview of the quality and cost performance categories last month. You can review materials from that webinar, including the slide deck, recording, and transcript on the QPP webinar library. For more information, next slide, please. Before we get started with today's presentation, I wanted to provide a brief update about our continued response to COVID-19. We're well aware of the impact that the COVID-19 public health emergency has had on clinicians nationwide. So we have again issued our extreme and uncontrollable circumstances policy for clinicians who want to file an application for the 2021 performance year. For MIPS eligible clinicians, groups, virtual groups, and APM entities unable to participate in the MIPS program because of COVID-19, this policy allows them to submit an application for reweighting one or more performance categories. The application is on qpp.cms.gov, and you'll need to select COVID-19 as the reason for reweighting. Again, the Extreme and Uncontrollable Circumstances application for the 2021 performance year is available on our website. We encourage you to sign up to our listserv on our website at qpp.cms.gov for more details on the application and other resources. Next slide, please. So now we'll provide a brief refresher of the Quality Payment Program. Slide, please. Quality Payment Program was authorized by the Medicare Access and CHIP Reauthorization Act of 2015, or MACRA, which required CMS to implement an incentive program. QPP consolidated 3 of our previous legacy programs: the Physician Quality Reporting System, or PQRS, Medicare EHR Incentive Program, and the Physician Value Modifier, VM. There are 2 participation tracks to QPP: the Merit-Based Incentive Payment System, which again we refer to as MIPS, or Advanced Alternative Payment Models, or APMs. Within MIPS, clinicians are subject to performance-based payment adjustment. If you participate in an advanced APM, you may be excluded from MIPS and eligible to earn a lump sum incentive payment if you meet certain thresholds. As mentioned, today's presentation will focus on 2 performance categories within the MIPS track of the Quality Payment Program. Next slide, please. Finally, I'll provide a brief overview of MIPS. Next slide, please. As you may be aware, MIPS assesses clinicians' performance under 4 different performance categories. Those are quality, cost, improvement activities, and promoting interoperability. This slide shows how each performance category is weighted to create your MIPS final score for traditional MIPS. Quality is weighted at 40%, cost at 20%, improvement activities at 15%, and promoting interoperability at 25%. Note that while we revised the weights for quality and cost this year, both quality and cost will be set at 30% in the 2022 performance year as required by law. For purposes of today's webinar, we'll be focusing on the improvement activities and promoting interoperability performance categories of MIPS. Again, you can now review the quality and cost webinar on the QPP webinar library for an overview of those 2 performance categories. Next slide, please. It's important to note that we define a MIPS eligible clinician based off their unique TIN NPI combinations. For those who may not know, a TIN is a tax identification number, and NPI is National Provider Identifier. So the TIN NPI combination helps us determine whether or not someone is eligible or otherwise excluded from the MIPS program. We encourage you to refer to the participation status lookup tool on qpp.cms.gov for information about your particular status. This chart also shows a brief summary of our performance years and corresponding payment adjustments. We'll get more information of that timeline on the next slide. Next slide, please. Finally, the 2021 performance year runs from January 1st, 2021 to December 31st, 2021. Data submission will follow in the first quarter of 2022 and then provide feedback later in 2022. Payment adjustments will be distributed in calendar year 2023 for that 2021 performance. We are now at the maximum amount of payment adjustment we can distribute, which is about up to 9%, and subject to a scaling factor to maintain budget neutrality. Next slide, please. Now I will turn it over to Jacqueline Rappaport to talk about the annual call for measures and activities and provide information for participating within the improvement activities performance category for the 2021 performance year. Jacqueline?
Thanks very much, Vidya. This is Jacqueline Rappaport, and I'll be talking to you about improvement activities. So just a quick overview of the call for improvement activities. So each year, CMS holds an annual call for measures and for improvement activities to both look for new, in our case, activities or modifications to existing activities. So we're currently in our period where we're accepting nominations that runs from February 1st through June. In this case, July 1st is the deadline for submitting new or modified improvement activities. And note that those nominations will be considered for the following rulemaking cycle, so next year's rule, for possible implementation starting in 2 years. So it would be for the 2023 performance year. And information on the call for improvement activities as well as for measures and PI measures is on the QPP website in the resource library as mentioned below. Next slide, please. So now I'll just talk more broadly about the performance category as well as things that are new for the 2021 performance year. Next slide, please. So just as an overview, this is the same as this has been in previous years for improvement activities. There are over 100 activities that are in the inventory for 2021 across 8 subcategories, and those are listed here. So these are just different categories. There's no requirement to pick anything from any specific subcategory. They're just organized that way for sort of easier sorting and identification of activities that might be relevant to you or your practice. Next slide, please. So in terms of scoring, just an overview of the IA basics and how it applies to your overall MIPS participation. As Vidya mentioned, in 2021, IA is worth 15% of the final MIPS score. and it's worth 20% for any MIPS eligible clinicians who are participating as an APM entity. Again, we're concentrating today on MIPS, but as a side note, it is slightly different for APM. So for 2021, there are 105 improvement activities, and the requirement, and this is the same as it's been in the past, is that the eligible clinician or group implement between 2 and 4 activities for a maximum score of 40 points. And I'll walk through the different scenarios for getting to that maximum score in just a minute. And again, as in the past, improvement activities only require an attestation. So you just go onto the QPP website. Again, we'll talk about this, and you just have to attest that, yes, you implemented the improvement activity. So at the time of attestation, no data needs to accompany that response. Next slide, please. So I want to go over the changes for 2021, relatively minor this year. So we do want to note that the COVID-19 clinical data reporting with or without clinical trial ID number ERP3, that improvement activity was implemented last year and is still in effect, so that can still be an improvement activity reported in the 2021 performance year. Also for this year, we modified 2 existing improvement activities, one related to the engagement of patients through implementation of improvements in using a patient portal, BE4, as well as comprehensive eye exam IAHE7. And the modifications are detailed on the QPP website if you want to see those changes. The other change we made is the removal of an obsolete activity, CMS partner in patients hospital engagement network, and that's because some of the details of that activity are no longer active. So we removed it from the inventory for this year. Next slide, please. So this is just a little bit more information about that COVID-19 improvement activity since it has been relevant for 2021. So there are 2 ways that MIPS eligible clinicians or groups can receive credit for IAERP3. So the first is to participate in a COVID-19 clinical trial using a drug or biological product to treat a COVID-19 patient and reporting those findings through a clinical data repository or clinical drug registry. The second way that you can participate in this IA is to participate in the care of COVID-19 patients and simultaneously submit relevant clinical data to a registry for ongoing or future COVID-19 research. And again, in looking at the complete inventory, you can see the complete description of this improvement activity as relevant. And we do just want to note, this is just a consideration, that another improvement activity that may also tap into some of that work that you may be doing if you're looking to attest to ERP3 is ERP2, which is about participating in 60-day or greater efforts to support domestic or international humanitarian needs. So that may be, again, depending on the work being done around COVID-19, may be a relevant improvement activity that could be submitted as well. But I just want to be abundantly clear that there's no requirement to submit any or any combination of IAs, but just to offer something that may be relevant for some clinicians listening in. Next slide, please. Okay, now I'm just going to talk a little bit more about participating in improvement activities. Next slide, please. So this is what I mentioned earlier, just to quickly go over the combinations of improvement activities that would need to be submitted to get a maximum score. So again, a maximum score is 40 points using a combination of 2 to 4 improvement activities. So improvement activities have 2 different weights. So medium-weighted improvement activities are worth 10 points, where high-weighted activities are worth 20. And so, again, there can be, to get to that 40, you either have 2 high-weighted, each worth 20, or 4 medium-weighted, each worth 10, or a combination, so 1 high-weighted and 2 medium. Next slide, please. I think there's a visual that accompanies this. Okay, so I think I went over this in terms of the weighting, but just to note that there are certain special status designations that change the weighting. So for small practices, non-patient-facing, rural, or health professional shortage area clinicians or groups, the weightings change, so that a medium weighted, instead of being worth 10 points, is worth 20, and a high weighted activity is worth 40 points. So in those instances, there are basically the score is doubled. Next slide, please. So here's the slide. So this is just representing visually basically what I just said in terms of the ways that you can combine improvement activities. And again, for the special status designation, that's essentially cut in half. And of course, if you do not attest to implementing any activities, you will receive 0 points for the performance category. Next slide, please. So again, this is just that sort of, if you were to cut it in half based on some of these special statuses, that's what the scoring would look like. Slide, please. Okay. So just to go over the participation here, there is sort of one other avenue that can be taken. As part of MIPS, instead of reporting either 2 to 4 activities, that a MIPS eligible clinician in a practice certified or recognized as a patient-centered medical home, or PCMH, will receive full credit for the improvement activities performance category. So that's kind of another avenue by which the IA credit can be achieved. If that happens, or if that's the case in your practice, you do still need to attest essentially to that status. So you can select PCMH, IA PCMH, as essentially an improvement activity for the purpose of attestation to say, I'm part of a PCMH, and that counts for your improvement activity score. The other thing I want to mention in terms of reporting as a group is that within a group, so within a TIN reporting for MIPS, at least 50% of the eligible clinicians in that TIN must be participating in that PCMH in order for it to count. So this is something that's evolved over the course of the program, but is important that that be considered when attesting to the PCMH avenue, essentially. Next slide, please. Just to mention again, I mentioned this briefly before, that if an eligible clinician or group is participating in a MIPS APM, they will automatically receive 20 points under traditional MIPS regarding improvement activities. So this is separate from MIPS APM participants if they're reporting via the APM performance pathway, otherwise known as APP, in which case they will receive full credit. So there's more information, again, related to APMs and how that scoring is done, but we just wanted to make a quick mention of it in this context. Next slide, please. Okay, and now I will just quickly tie things together in terms of the reporting and scoring requirements for improvement activities. Next slide, please. Okay, so I mentioned this, but again, to report an improvement activity, MIPS eligible clinicians and groups and APM entities, to the degree they are doing this, simply attest to having completed their improvement activities. And the submission period, or the attestation period in this case, runs from January 3rd, 2022 to March 31st, 2022. So it's the first quarter of the year subsequent to when the activity is being performed. And this is important as well, that as I've mentioned, attestation is how you submit essentially your information for improvement activities. But although you do not need to submit any supporting documentation when attesting to the completion of an improvement activity, you should have documentation that the improvement activity was completed, and it must be kept for 6 years subsequent to submission. And if there are any questions about the kind of documentation that would meet the criteria for the improvement activity you're submitting, you can look at the MIPS data validation criteria. There's a link in these slides, and the slides will be shared at a later date and time. And so this link is also on the QPP resource library. And this just lists a little bit more information to support clinicians in terms of understanding what data can be kept to document participation in improvement activities. So while it doesn't need to be submitted when attestation happens, it should be kept for future reference. Next slide, please. Okay, so attestation data can be submitted through one of the following submission types. A clinician or a practice representative can sign in and manually attest through the QPP website. Clinicians or third parties can upload a QPP JSON file with the activity attestations, and a third party can directly submit via computer-to-computer interaction using the QPP API. So those are the different ways that that data can be submitted depending on who is submitting them. And there is also on the QPP Access User Guide, another document in the resource library, there's more information that details how attestation can occur. And this also details, if you're working with QCDR, Qualified Registry, there's more information on how that works as well. Slide, please. So this was mentioned, but just to kind of sum everything up in terms of scoring, the improvement activities score is worth 15% of the MIPS final score. And so getting up to your 40 points, it gets you your 100% of your improvement activity score. Next slide, please. All right, now that we've gone over all the basics on improvement activities and the changes for this year, I will pass it to Elizabeth Holland to talk about the Promoting Interoperability performance category.
Thank you, Jacqueline. As Jacqueline mentioned, I'm Elizabeth Holland, and I'm going to walk you through the Promoting Interoperability performance category. Next slide, please. So I'll start with the basics. Essentially, the Promoting Interoperability performance category is what used to be called the Medicare EHR Incentive Program. So everything, all the measures in the program are based on certified EHR technology. Next slide, please. So for the 2021 performance year, as Vidya mentioned, the Promoting Interoperability performance category is worth 25% of your final score. The performance period is a minimum of 90 consecutive days, and those days, that's the minimum. You could do anywhere up to the whole year. You can just choose any period you want up to the full year. All of the scoring is performance-based, and you must use certified EHR technology. More on that later. Next slide, please. So we do have hardship exceptions, and I'm going to talk about several types, but just off the bat, I wanted to talk about the hardship exceptions that you must apply for. And so we have the hardship exception applications on the qpp.cms.gov website. You would apply there, and you would choose whichever category applies to you. So if you are a small practice, that means 15 or less, you are eligible for this exception. You just have to apply for it. And you apply, as I said, via the website, and you find out pretty quickly whether you're approved or not. We have other categories as listed here: extreme and uncontrollable circumstances, lack of control over certified EHR technology, and just not having CERT does not qualify for hardship exception. Please note, you have to apply for the hardship exception before December 31st, 2021. So that's right before the beginning of the data submission period. If in 2022 you decide yes, even though you have a hardship exception, if you decide you would like to submit data anyway, you could do that, but we would cancel the hardship exception. Next slide, please. And now I'm going to walk you through some of the reporting requirements as well as scoring. Next slide, please. Okay, so the Promoting Interoperability performance category has 4 different objectives: e-prescribing, health information exchange, provider-to-patient exchange, and public health and clinical data exchange. You must report on these measures to earn a score. So if you have a 0 in any of these categories and you don't qualify or claim an exclusion, you would fail the Promoting Interoperability performance category. Next slide, please. So, for certified EHR technology, in the rule last year, we already had the requirement that you must use 2015 edition cert. But we updated that requirement to say, okay, you could also use the 2015 21st Century Cures update version, or you could use a combination of both. So we're giving you the flexibility to make a choice of what kind of cert you want to use, and that will be available through 2021 and 2022. Starting in 2023, you must be using only the 2015 edition Cures update. And the cert functionality must be in place on your first day of your performance period, but it doesn't need to be certified officially through the Office of the National Coordinator for Health Information Technology until the last day of the performance period. Next slide, please. Okay, so to report, you need to submit your data for all the required measures. There are also some additional attestations you must complete that are not scored, but if you do not complete them, you will not earn a score. So those are the Prevention of Information Blocking attestation, the ONC Direct Review attestation, and the Security Risk Analysis. So the Security Risk Analysis must be reviewed or performed within the calendar year. And as I mentioned before, for the measures with the numerator and denominator, you must have at least one in the numerator and one in the denominator to fulfill the requirements of this performance category. Next slide, please. Okay, so some of the changes for 2021, we added an optional bidirectional exchange measure. So now under the Health Information Exchange, there's two options. You can do the two old measures, which I'll show on a next slide, or you can do you can do the two existing, or you can do the new bidirectional exchange measure. I mentioned that we changed the certified EHR technology requirements. We also increased the number of bonus points available for the Query of Prescription Drug Monitoring Program, or PDMP, from 5 points to 10 points to just show how serious we are about trying to combat the opioid epidemic. And we updated one of the measure names by incorporating to reconciling, because we actually do not require you to incorporate data unless it is necessary. Next slide, please. Okay, so now we're going to walk through all the measures. As I mentioned, the first three are required, but they are not scored. And so you must attest yes to these, or you earn a score of 0. There is an additional attestation there for surveillance. That is optional, and you can fill it out or not. It's your choice. The Query of PDMP is also optional. Next slide, please. Okay, so here you can see the measures that are required. PDMP is on here again just because it's one of the optional measures. E-prescribing, so you would submit your numerator and denominator, and we calculate that to earn a score. The provide patients electronic access to health information, there's no exclusion for that, but you would submit your numerator and denominator. And as I mentioned, the two existing are the support referral loops by sending health information, and the support electronic referral loops by receiving and reconciling health information are the two existing HIE measures. You can either do those two, or you can do the HIE bidirectional exchange. There is no point to doing all three. We will only score one or two of them, depending. I believe if you submit the HIE bidirectional and the other two, we only score the HIE. We don't score anything else. Next slide, please. And then for public health, you have a choice to submit to 2 different public health or clinical data registries. And what that means is you can choose 2 different registry types, or you can choose within the same registry type if you are submitting to 2 different registries. For example, if you're in public health and you're submitting to 2 different agencies, that would count as 2. Next slide, please. Okay, so as I mentioned, the score is weighted at 25%. The total maximum score you can earn is 100. So even though if you get perfect scores on everything plus do the bonus, you would earn more than 100. It's just capped at 100. And we take your score in points and we multiply it by the weight to get your number of points that we apply towards your final score. Next slide, please. So here is an example of how we calculate the performance rate. This is for e-prescribing, and the numerator is 200, and then the denominator is 250. So that results in a performance rate of 80%, times the total weight for the particular measure, which gets you at 8 points. We would do this for each of the measures to get the total points, and then, like as on the previous slide, we would calculate your final score proportion. Next slide, please. So I did mention that you choose 2, and there are exclusions available for each of these measures if you qualify. And so you need to read the verbiage on this specific exclusions, and you have to tell us you qualify by checking yes for the exclusion. And I refer you to our QPP resource library, where we have Promoting Interoperability measure specification sheets, and there's a sheet for every single measure, and it goes through all the exclusions for that measure and other relevant information about the measure. Next slide. Okay, so this is a little confusing, but I'll walk you through it. So if for public health, you submit 2 measures, you earn 10 points. If you submit an exclusion for one and a yes for another, you still earn 10 points. If you claim 2 exclusions, the 10 points allocated to the public health and clinical data exchange objective will be redistributed to the provide patients electronic access to their health information measure. If you can attest yes and can't claim any exclusions, you will get a score of 0 for the measure and for the whole Promoting Interoperability performance category. Next slide, please. Okay, now we're going to talk about reweighting. Next slide, please. Okay, so we have 2 different kinds of reweighting. One is where you would file an application, and the others are automatically. If you are reweighted, the 25 points that is allocated to the Promoting Interoperability performance category will be redistributed to another performance category. Next slide. So one of the ways to be automatically reweighted is to be one of particular of these clinician types. I won't read them all, but you can see there are quite a few. So if you are identified in PACOS as one of these clinician types, you will automatically be reweighted. But as I mentioned before, if you're reweighted and you submit data, that reweighted is canceled. So think about if you're one of these types, think about whether you want to be scored on the data or if you want to be reweighted. Next slide, please. Another type of reweighting is if you are a special status. So for ambulatory surgical center-based clinicians and these are clinicians that bill 75% or more of their services in an ambulatory surgical center, and that's place of service code 24. They would be classified as ambulatory surgical center based and therefore reweighted. For hospital based, it's the same thing, except there we're looking at place of service code 19, which is off-campus hospital, place of service code 21, which is inpatient hospital, place of service code 22, which is outpatient hospital, and place of service code 23, which is emergency room. And if you're non-patient facing, like an anesthesiologist or somebody like that, you would also be automatically reweighted, and CMS would calculate that. Next slide, please. And just before I get to data, I will remind you that those were the automatic reweighting types. And in the beginning of the slide, the Promoting Interoperability slides, I mentioned the particular categories that get reweighted if you submit an application. And remember, our application period for hardship exceptions is open now. Okay, now to submit data, there are 3 ways to submit. You can go to our website and attest to your information. You could upload a file, or you could do a submission using an application programming interface. Next slide, I believe I am turning it back to Vidya.
Thank you, Elizabeth. Next slide, please. So on this slide, we've listed additional helpful resources. We encourage you to refer to the 2021 Improvement Activities and Promoting Interoperability user guides for details on the 2 performance categories for 2021. All of these resources are available on the QPP resource library. Additionally, CMS will post the slide deck from today's presentation to the QPP webinar library, along with the recording and the transcript, if you'd like to go back and review anything. Next slide, please. Before we move to the Q&A portion of the webinar, we'd like to remind everyone of some helpful services that are available. We offer no-cost technical assistance for small, underserved, and rural clinicians who need it. We encourage you to check it out if you qualify. We also have agents available at the QPP Service Center to help answer any questions you may have, and you can reach them at 1-866-288-8292. For TRS, dial 711, or you can email qpp@cms.hhs.gov. Finally, we have resources available on the QPP resource library, and previous webinars are posted to our QPP webinar library. Next slide, please. So now I will turn it over to Ketchum to begin the Q&A.
Thank you, Vidya. We are now going to start the Q&A portion of the webinar. You can ask questions via chat or phone. To ask a question via phone, please dial 1-833-376-0535. If prompted, provide conference ID number 975-9569 and press *1 to be added to the question queue. So we will start by taking a few questions that we received via the chat box. The first one says, for the public health registry under PI, are practices allowed to exclude from reporting any registries for 2021, or is at least one required?
For 2021, the requirement is to report to 2 different registries, but you could report to one and claim an exclusion if you're eligible.
The next question says, can a hardship exception be filed 2 years in a row if COVID again is a circumstance that falls under the EUC?
Yes, there was a limitation on hardship, and there is still one for hospitals, but for MIPS eligible clinicians, there are no limit to the number of years you can file for a hardship. And for promoting interoperability, you could file a extreme and uncontrollable circumstance hardship for the reason of COVID.
Thank you. The next question that we received through the chat reads, can you please elaborate the difference between the electronic case reporting measure and the public health registry reporting measure?
So the public health registry reporting, the registry must be sponsored by a governmental entity. So it would be a state government, a local health department, or the federal government. And the electronic case reporting is reporting of particular cases, but it could be either hosted by a governmental agency or a private entity.
Thank you. The next question reads, if you are non-patient facing, do you have to participate in PI measures?
If you go into our QPP website and you look up your status, it should say your status, whether you're non-patient facing or not. And if you are designated as non-patient facing, you do not need to submit promoting interoperability data.
And we are receiving quite a few questions around small practices. So someone asked if you can provide a high-level definition of what constitutes a small practice.
15 or less clinicians.
Great. And do we have any questions on the phone line?
There are no questions at this time.
Thank you. We received a few more through the chat box. So the next one reads, if using CAPS for an improvement activity, what time frame should be used when reporting?
So all the specifications for the improvement activities are in the descriptions. As a default, most improvement activities need to be submitted for or need to be performed over a course of 90 days. For CAPS, I believe the way that works is slightly different, and I can't speak to that, but it's detailed in the description of the activity. And I invite someone else if they want to jump in on that.
That's correct, Jacqueline. The requirement should be listed in the validation criteria document.
Great. Moving on, the next question reads, can a provider claim bonus points for PDMP and claim the e-prescribing exclusion?
No.
The next question says, if the HIE allows us to send them patients and we get an alert via email but not direct into our EMR, would that meet the expectation for the bi-directional exchange?
No, the data has to be flowing both ways.
The next question is the patient-centered medical home status still based on sites, or is it based on 50% of the providers?
I believe it's 50% of the NPIs in the PCMH.
The next question, as a small practice, am I required to apply for the PI hardship exception every year?
Our policy now is yes, you would need to apply every year. And for all hardships, they're only good for 1 year. So if you apply now, you're getting a hardship for reporting for the 2021 year. And next year, if you're eligible again and want to claim a hardship, you need to apply again.
Great. The next question, what is the best source to obtain information of what is required to be an eligible provider?
I would say probably our QPP website.
This is
And that's
Michelle. There's also on the QPP website, on the resource page, there's actually a thing about eligibility, and it tells you exactly what it takes to be an eligible clinician.
And again, that's qpp.cms.gov.
The next question says, what % of providers need to participate in an IA measure for the measure to be eligible to attest?
So for improvement activities, the policy is that each improvement activity that's attested to, 50% of the NPIs billing under the TIN need to participate in that improvement activity for any continuous 90-day period. So that means so the TIN reporting, 50% of those clinicians need to do the same activity during some period of time during the year. Some 90-day period or the period that's specified in the activity.
Great. The following question reads, can you report the same IA activity that was reported in previous years?
Yes, unless the activity description specifically says that you cannot, and that's only a handful of cases.
Next question, if in a large group, I believe IA requires 50% participation, do the IA have to occur for all of these providers during the same 3 months?
Not the same 3 months. They have to do it for any continuous 90-day period. Again, if 90 days is the period specified, then they don't all have to, that 50% do not all have to do it in the same 90 days.
Great, thank you. Next question, could you elaborate on the requirements for HIE bidirectional measure?
Can we come back to that?
Of course. Do we have any questions on the phone line?
There are no questions at this time.
Okay, just a reminder to everyone, if you do want to ask a question through the phone line, please dial the information that is showing on this slide. We do have a few more questions that have been submitted through the chat. Next one reads, if some of the providers in the TIN are one of the clinician types where there is reweighting available, can their data be reweighted for PI, or they still need to submit PI data as the group?
They still need to submit PI data as a group.
Next question, if you have a status such as non-patient facing that allows the PI category to be automatically reweighted, can you submit PI data to override the reweight? Or does submitting PI data to override the reweight only apply to those who submit the PI small practice hardship application?
No, for any reweighting, so that's automatic or for hardship exceptions, if you are reweighted and do not submit data, those 25 points get redistributed to another category. But if you are reweighted and you choose to submit data during the submission period, we will cancel reweighting, whether it was automatic or by application, and it doesn't matter which type, we will score the data and cancel the reweighting.
Thank you. The next question says, how can we find out if our state is an HIE state for the HIE bidirectional measure?
We're not requiring you to be in the state HIE, it's any HIE. So you just have to figure out whatever health information exchanges are available in your area if they are capable of doing health information exchange. And that's partially why we gave people a choice for HIE, because we knew everybody wouldn't be able to do this measure, even though we believe it's really very important. The reason we added it was because there was an outcry from clinicians who couldn't get data on their COVID patients, and this was really seen as a way to help facilitate the movement of data so that clinicians can better treat their patients. And so I wanted to come back to the question on the bidirectional exchange through health information exchange. So there are a series of attestations that you need to be able to attest yes to fulfill this measure. And so first one is, I participate in an HIE in order to enable secure bidirectional exchange to occur for every patient encounter, transition, or referral, and record, stored, or maintained in the EHR during the performance period. The second one is, the HIE that I participate in is capable of exchanging information across a broad network of unaffiliated exchange partners, including those using disparate EHRs, and does not engage in exclusionary behavior when determining exchange partners. And the third statement is, I use the functions of CERT to support a bidirectional exchange with an HIE. So if you can answer yes to all of those questions, and you may need to get the answer from the HIE, you can answer yes to all those attestation questions, and you are connected to the HIE, then you can attest yes for this measure. I hope that helps.
Thank you. The next question in the chat reads, is there still a requirement that 50% of providers in a group must participate in the improvement activities in order to succeed?
Yes. And again, I said this in a previous response, but 50% of a group needs to participate in the same improvement activity, but they don't all have to do it at the same time, if that helps. And I just wanted to jump in and say something I said before was incorrect. I just want to clarify the question about patient-centered medical home. It's 50% of the sites in a group must be certified PCMH, not 50% of NPI. I'm sorry, I mixed that up. So apologies to that person who asked that question.
Thank you. The next question says, is it a requirement to submit supporting documentation for improvement activities to a registry if you use a registry to report for you?
Sorry, can you repeat the question?
Of course. It says, is it a requirement to submit supporting documentation for improvement activities to a registry if you use a registry to report for you?
So the requirements for 2021, no, you just have to attest, but I work with your QCDR and QR for what they may need to report on your behalf. But the requirement from CMS is then no, you do not have to submit any documents.
Thank you. The next question reads, for improvement activities for one clinician, what is the minimum number of patients the IA data validation has to be completed for the 90-day reporting period? 1 patient, 10 patients, is there a minimum percentage?
No, there's no patient threshold for the requirement.
Thank you. And just to check, do we have any questions via the phone line?
We do have one question. Caller, please ask your question.
Hello, can you hear me? Hello? Hello?
Yes, we can hear you.
Yes, we can hear you.
Okay. The question is actually also related to the HIE bidirectional exchange. You already kind of mentioned that you have a certain kind of a statement. My question is that if like a provider using a particular like a HIE exchange program, do you have a list of something like or what is considered if you want to say a certified HIE exchange program? And also my another question is that what kind of documentation that one need to prepare in order to demonstrate that you are satisfying this measure. I think that there's not much information at this moment in terms of on this measure. You mentioned about that the support statement you need to check this yes or no, but I don't find anything so far is that on those statements, because I look at into the CMS website, there's no like a detailed explanation in all these statements. Yeah.
I know the statements are in the regulation and they are on the specification sheet for that particular measure. CMS has declined to issue a list of HIEs that could qualify because they're always changing, merging, etc. And we don't want to be seen as endorsing any particular HIE over another. Any other? Did I forget something?
Yeah, I think it's what kind of like a documentation that is, because I find it that because that one that need to keep documentation for 6 years in case that CMS want to conduct an audit for that. So I'm just kind of thinking ahead in terms of say in order to satisfy that, and also that in case of a situation like this, so what do I need to prepare in terms of to show that I satisfy the measure? So
I believe we have that in our resource library.
Right. Okay.
And we have it actually for each measure, where we say what documentation should be kept.
Yeah. I'm specifically I'm sorry. I'm specifically on the bi-directional exchange. So because it's new, so I think it's I think to me it's a little bit it's not very clear to me is that what needs to be done. So
yeah, I'm pulling up. We have a 2021 MIPS data validation criteria publication that's on our resource library. I'm just trying to pull it up to see what it says. So what it says on the document is a dated report or screenshot that documents successful receipt and transmission of patient data via the entity providing health information exchange services should include evidence to support that was generated for the MIPS eligible clinician system identified by the National Provider Identifier, clinician name, practice name, and or a letter, email, or other documentation from the entity providing health information exchange services confirming that the participation of the MIPS eligible clinician, the date of the onboarding, a description of services provided, and a description of exchange network participants, that is the number, type of participating providers, or a letter, email, or other documentation from the MIPS eligible clinician's certified EHR technology vendor confirming a connection between the eligible clinician cert and an entity providing health information exchange services. The date of the onboarding, a description of the services provided, and a description of the health of the exchange network participants, that is the number, type, participating providers for the duration of the period. And again, I was reading from the 2021 MIPS data validation. We have separate reports for each performance category. So if you're submitting data for MIPS and you want to know what documentation is suggested, this is not saying this documentation is all, but it gives you a number of examples of what could be submitted, what should be retained. And so we have them for each performance category, and I was just reading from the Promoting Interoperability one for the 2021 MIPS data validation. I hope that helps.
So this is in the resource library, right?
Yes.
Okay. Yeah. Okay. Then let me go to look it up. So hopefully that they will make it clear. Okay. So I haven't looked into that yet.
The 2021 MIPS data validation criteria.
Okay. Thank you so much.
Great. And do we have any other questions via the phone line?
We have one more question. Caller, please ask your question.
Hello?
Hi, we can hear you.
Okay. I was late to the party and didn't realize with the time change, so this may have already been addressed, but are these slides going to be available after the webinar is over? And also, is there any recording of it?
So this is Vidya. Yes, we will, in the next few weeks, we will post this webinar as well as the transcript and the recording, so you can go back and listen to it and read it.
Perfect. Thank you so much.
Thank you. And just confirming, are there any other questions on the phone line?
We have one more question. Caller, please go ahead with your question. Your line is open.
Hello.
Go ahead.
All right. So again, in reference to the HIE bidirectional category, I just jumped in a little late while you were discussing the previous question. So when it states that I participate in the HIE in order to enable secure bidirectional exchange to occur when the physician attests to that, does it have to be, it says it has to be for each encounter, every patient encounter, transition or referral, and record stored or maintained in the EHR during the performance period in accordance with applicable law and policy. So does that mean for each and every encounter, meaning like the transition of care, referral, or does it mean for every patient? The other question I had was also, does the information have to be exchanged electronically as they are currently doing for the incorporating and reconciliation requirement? Would it stay the same for the HIE bidirectional as well? Or it can be documented in the patient chart, it can be faxed, or
No, the information must flow electronically, no faxing.
Okay.
And it is for every patient encounter, so for all patients. So you would have it on, and information would be flowing for the whole performance period.
Okay, so for every patient, meaning like when they receive the transition of care, or when they receive the referral, or would it be just every single patient?
Every single patient.
Every single patient. Okay. Thank you so much.
Thank you for your question. Are there any final questions via the phone line?
No additional questions at this time.
Thank you. We did receive a few others via the chat. So the next question reads, if we submit data for eligible clinicians under a group TIN rather than submit data for individual ECs, do the providers that are automatically reweighted get reweighted under the group TIN reporting as well?
No, if they choose to be part of the group, then they submit data with the rest of the group. It's only if they're reporting as individuals that they would have the reweighting. And that said, if a group is 75% or more hospital-based, for example, the whole group would be reweighted.
Thank you. The next question says, for IA, do small practices still get double point credit for each measure?
So you have to look up the status in terms of whether you are, a special status. But if that is the case in terms of the definition of small practice, then yes, that's the case, that each IA is worth double the points.
In the next question, if your providers submit improvement activities for different 90-day periods, how do I select the reporting period to attest to?
So the information on how to do that, depending on the pathway, is on the QPP website. So the instructions are there. If you have more specific questions, I suggest you follow up via the help desk. It's just going to be an easier way to ensure that that's communicated.
Our next question, do we have to provide the documentation for security risk analysis, or is it just the attestation?
It's just the attestation. You just need to retain the documentation.
Thank you. The next question says, if a TIN is in an APM and has a PI exception, they don't submit anything in the APP, but the APM submits quality metrics and PI rolls up, will they still get the APM MIPS score?
Sorry, I can't speak to APM scoring.
Thank you. Our next question says, if you are a rural practice, do you need to submit an exemption request, or is it automatic?
I don't believe we have any special treatment of rural practices under MIPS.
Our next question says, does the HIE have to be 2015 cert or CURE cert?
Either one.
Thank you. Are there any new questions via the phone line?
No questions at this time.
The next question in the chat box reads, we are a small practice APM participant. Do we still get double points for submitting improvement activities?
Again, the scoring is different. Under APM, it's going to depend on the circumstances of what type of APM, so I suggest you follow up via your APM, essentially, to figure out what your requirements are.
Thank you. Our next question says, for the PI category, the HIE objective has two measure required referrals be sent or received. Can patients counted for this measure be counted for the IA bilateral exchange of information?
You can't report for all of the HIE measures. You either need to choose the two existing, which is the support electronic referral loops by receiving and incorporating, and the other existing is supports referral loops by sending. You either do those two or you do bidirectional exchange. You don't do both.
Thank you. Our next question reads, does patient-centered medical home satisfy the entire IA category?
Yes. You still have to report it. So if you have to be a certified PCMH, and there's details on what counts on QPP on the QPP website. If you look at the improvement activities page, and you still have to attest. So when you attest for your IAs, you still have to select IA PCMH and submit that. But assuming you meet the requirements, yes, that's all you have to do.
Great. The next question we received, does PI and IA have to be reported for the same time frame or quarter?
Nope.
No.
Do we have any questions submitted via the phone line?
There are no questions at this time.
The next question, we had somebody ask if you can please revisit whether or not you have to submit new IA each year.
No, you don't, unless there are a small handful of improvement activities that specifically give a requirement of if there's a limitation on how many times you could submit, but almost all the IAs have no such requirement.
Thank you. Our next question says, must a provider be connected to an HIE for the entire 90-day reporting period, or is there a minimum to be able to attest yes?
No, it must be for the 90-day reporting period. And if you attest yes, you get 40 points.
Our next question says, if a new provider joins our practice in June of 2021, do we have to include them for MIPS data submission in 2021? We submit data as a group since we're a small practice.
I think we have information on the website to determine if they're eligible or not.
Thank you. Our next question says, what are the required fields for provide patient access? Have they changed quite a bit from 2020?
I think they're the same. I think they may change slightly when you switch to the 2015 Cures update, but if you're just on 2015 CERT, there's no changes.
The next question says, if a provider type is reweighted, how is it reweighted? Is it reweighted to 0?
It's reweighted to 0, and the performance category weight in the instance of promoting interoperability is 25, and so that would be reallocated to another MIPS performance category weight.
Great. The next question says, if we report the bidirectional HIE measure for PI, can we also report to it for IA?
No, there's no, the measures for PI are completely different from the improvement activities.
Thank you. And just checking, are there any questions submitted via the phone line?
No questions at this time.
Thank you. A few more questions in the chat. One says, does the exclusion cover the entire MIPS reporting, improvement activities, promoting interoperability, or is there no reporting at all?
I'm not sure I understand the question. For PI, an exclusion just refers to a particular measure if you claim it. Reweighting would apply to the whole performance category.
Thank you. Our next question says, for the PI hardship, if the practice only has 2 providers, does it matter how many patients they serve, or is it considered a small practice?
15 or less clinicians. So if they have 2, they would be considered small. And another question came in about the small practice exclusion. Does that mean they're omitted from any incentive? No. If they claim the small practice exclusion for promoting interoperability would move those points to another performance category, and whether or not you get a positive update or a negative update depends on your total MIPS score. So it does not disadvantage you to have your points moved because you still have the same total number of points that you could earn.
Thank you. We received another question that says, do small groups still get the bonus for improvement activities?
There's no bonus for improvement activities. I'm not sure if what this person is referring to is, as we've talked about before, special status. If they qualify as a small or rural or otherwise exempt entity, then the scoring is different. So not sure if that answers the question.
We did receive a question that is specific to improvement activities for practices with multiple providers. And it says, if the 90-day periods of time are scattered throughout the year for multiple providers, should the full year be attested to? Or simply the date ranges the actual IAs are documented, which may be longer than just 90 days?
Right. I believe in that case you just can attest to the year. Essentially, you attest that you did it. Overall, you don't have to provide that level of detail.
We received a question that says, will small practices have an exemption option for 2021 promoting interoperability performance?
Sorry, could you repeat that, please?
Of course. Will small practices have an exemption option for 2021 promoting interoperability performance?
Yes, this whole webinar has been based on what you need to do for 2021. So yes, there is a hardship exception that small practices could claim, but they have to apply for it. It's not automatically given to you.
Thank you. And our next question says, is there a list of recommended improvement activities for private practice physical therapy?
So for any clinician type, we have what are called specialty guides. They're on the QPP website, and for different specialties, there are suggested, not required, suggested improvement activities, as well as recommendations for other categories. So you can look up for your clinician type, your specialty, what improvement activities may align. But again, these are suggestions and not requirements.
Thank you. One participant submitted a question that reads, if participating in an ACO, do we need to attest to IA activities?
It depends on the type of ACO. I would work via your ACO to determine essentially your category in the context of the quality payment program and how that affects your status in terms of reporting IA.
Our next question reads, with a small practice exclusion, is the practice then omitted from any incentive?
No, it just means that you would not receive a score for PI, that 25 points would be reallocated to another measure, and so you would still have the opportunity to earn the total 100 points. You would just be getting there through a different combination of performance categories. So yes, if you scored high enough, you would get a positive incentive, and if you score lower, you'd either be neutral or downward.
Great. Our next question says, is it true that a letter from the HIE will be acceptable for audit purposes for PI category?
I believe that is one of the things I mentioned in that MIPS data validation. So if there are other questions, you should review the 2021 MIPS validation document. It has all the information for all the measures for all the performance categories of what would be acceptable documentation to retain.
Thank you. And one participant asked for clarification saying, do those 50% improvement activity providers participating in a given activity have to attest to the same IA measure?
Yes. So it's not a measure, it's an activity. Yes, the 50% need to do the same improvement activity. The clarification is that they don't all have to do it simultaneously. So as long as that 50% of the NPIs in the TIN are doing a given improvement activity for the defined period of time, sometime in that year, then it works.
Our next question says, is there information available for when API submissions for promoting interoperability and improvement activities for eligible clinicians will be required?
We're certainly working on that, but we have not released any public information yet.
Thank you. And just checking, are there any questions submitted via the phone line?
No questions at this time.
Our next question says, for the measure of HIE, are we still allowed to claim that measure as an exception?
No.
So for the support electronic referral loops by sending health information and the support electronic referral loops by receiving and reconciling information, I believe there are exclusions. And so if you claim the exclusions, those points will be reweighted. There is no exclusion for the HIE bidirectional. So if you don't report it, you just don't report it. Then you would be reporting the other two measures that I just mentioned.
Thank you. And somebody asked if you could please clarify, if a hardship exemption is granted, does that mean there's no reporting?
If you apply for a promoting interoperability hardship and you're approved, you would not be required to submit promoting interoperability data. If you choose to submit data, the hardship would be canceled. You would still need to submit data for the other three performance categories, however.
Great. And we had a question specific to e-prescribing that says, if you prescribed under 100, could you exclude from e-prescribing?
Yes, I believe that is the exclusion, but I would definitely refer you to our specification sheets because it gives the exact language of the exclusion. And so for any exclusion, they're not applied automatically. You need to claim them when you're submitting your data.
Thank you. Our next question, will the EUC be auto-applied again, or will eligible clinicians be required to register?
I believe that there's only an EUC for Texas for 2021.
Just checking one last time, do we have any questions submitted via the phone line?
There are no questions at this time.
Great. Don't see any additional questions through the chat line. So Vidya, I will turn it back over to you to close us out.
All right, thank you. Thanks to all of you, and thank you for your questions today. We hope this helped provide an overview for participating within the improvement activities and promoting interoperability performance categories for MIPS for the 2021 performance year. Again, we encourage you to download materials from the QPP resource library for more information. You can also sign up to our listserv at qpp.cms.gov to remain updated on news and announcements. Slide. Finally, the slide deck recording and a transcript of today's presentation will be posted to the QPP webinar library in the next few weeks. Again, thank you for joining and have a great day.
Thank you. This concludes today's conference call. You may now disconnect. Speakers, please hold the line.